Rahman Ar-Rahim. I'd like to start by thanking the organizing committee for inviting me to share my experience and for all their wonderful efforts. Since this meeting has so many different specialties involved, I thought I would concentrate mainly on the clinical aspects of Down syndrome, highlighting areas I felt were important for families and caregivers. So, the clinical issues in Down syndrome. First of all, it's the most common cause of genetic cause of intellectual disability. Now, this may or may not be a clinical problem in itself, but it's important to know that health problems can affect learning. And the more you control the health issues, the more likely the child is to have a chance of development and learning. So first of all, we have the visual issues, and these can occur in more than half of the children. And there's a variety of visual issues that occur, and so we like to screen vision several times in the first year and then throughout childhood and adulthood. Hearing issues can occur in more than half of the children as well, and these are due to a variety of reasons. So a structural abnormality, just like the bones outside that we see, the external bones are short, where you have a short nose and short fingers, for instance, you might have short bones inside the ear canal, and that will change the conductiveness of the system. Also, the different structure where the canals are more wide, and therefore are more likely to have recurrent infections, and therefore, again, a conductive cause of decreased hearing. There can also be problems with the nerve itself, and in one child, you might actually have more than one issue occurring at the same time. It is very important to delineate what is the cause of the hearing defect in order to give appropriate treatment. And some children will have hearing and visual issues, and this will be very detrimental to their learning unless they're diagnosed very early. So regarding hearing, for instance, if we wait until the mother or the caregiver or the father notices that the child is not hearing, then we might miss a very important window of opportunity for developing speech that cannot be made up for. And that's why we do the screening frequently. Thyroid problems. So you can think of thyroid as that gland in here that affects metabolism. So if you're hyperthyroid, everything is fast, your heart rate, you're anxious, you're sweating, you're losing weight. And if your thyroid is slow, then everything slows down, and your heart rate, and you get constipation, and so on. And children with Down syndrome can have either hyper or hypothyroid, or they can have both at different times of their life, and so we do screening for that. And hypothyroidism in early childhood will affect learning, and therefore we screen frequently in the first year of life and treat immediately. Children might have dental problems, and it's always good to have a dentist, a pediatric dentist that is comfortable and familiar with Down syndrome, looking after them. 1/3 are born with structural heart abnormalities. Some of these are asymptomatic, but it's always important to be aware of these and to follow them up. There are gastrointestinal issues that can occur throughout the lifetime of individuals with Down syndrome, and they are prone to different infections of the ear, the respiratory tract, and the skin and other organs. Finally, autism and other psychiatric or psychological problems may occur, and although those are not in the realm of the clinical person, it is important to make sure none of these clinical health issues is a cause of the sign that we see here. Okay, and then there are more problems. Now, I'm going to give some examples, and I'm starting with family A, and I called her Mariam. This is not her real name. But this is a 5-year-old girl with Down syndrome who is growing appropriately and learning new skills. But her stool was hard, and it was causing her to cry. So every time she goes to the bathroom to defecate, she has pain and she cries. And so she starts to avoid going to the bathroom. The more she avoids going to the bathroom, the more the stool becomes hard. And finally, when it does come out, it causes pain and a little bit of bleeding. And so she becomes more uh, intentionally avoiding the bathroom. And it's a vicious cycle that some children go into. So constipation is a common problem, and it is a serious problem, and it occurs in Down syndrome. One of the important causes is hypotonia. So the tone, the muscle itself is lax, just like we see in the hands. They're lax, the feet are lax, the legs, the jaw is lax, and the same thing happens with the muscles inside. So the intestines are lax, and this causes constipation. It's also noted that children with Down syndrome don't really like to drink water, and the decreased water intake also causes these issues. And I like to tell the moms from the beginning, really early on in life, to give your child just touches of water. Later on, make them into sips, and then as they grow older, increase the amount. Because children with Down syndrome, I've seen children come to the clinic at the age of 3 or 4, and they just don't drink water. They drink orange juice, they drink milk, but they don't like water. And it's very difficult to start to teach them that later on in life. Okay, why do we need to prevent it? Because we don't want to go into that vicious cycle, and once we do that, we go into it, it starts to disrupt your daily life. And so with every visit to the clinic, I ask the parents about the consistency of the stool, how many times the child goes, is there any crying, any pain, and I examine the child to make sure there's no early signs of constipation. And I always give them dietary advice how to avoid it in the first place. Okay, let's talk about our next patient. This child, his name is Majid. He's a happy, healthy 3-year-old with Down syndrome. He went for a routine check. So many of you who've worked with children are familiar with these charts, or if you have children yourself. And so we plot the length in centimeters or inches here, and the weight in kilograms or pounds against the child's age. So here at the age up to 36 months, and then the charts for older children. And we're happy when we find the child growing appropriately along their chart. Once the child starts to drop off here or go above normal, then we might need to investigate the cause. So let's do this for Majid. Majid's weight is 14 kilograms. He's 36 months. So it's somewhere around here, and this is within normal. And then his height, 85 centimeters, which is this one, is way below the normal. And so the parents start to get worried. But here I need to tell you that there are special growth charts for children with Down syndrome. And some healthcare providers, understandably, are not aware of this. So what you need to do is plot the height and weight on Down syndrome charts appropriate for the child. So let's do that for Majid. Now this is the weight, 14. This is the length, 85 on the normal chart. Now on a Down syndrome chart, this is the length and this is the age. So he's 36 months and his height is 85 centimeters. So now we can see that it's normal for a child with Down syndrome. Okay. Now, if the length was somewhere around here, 75 or 78, then I would worry and I would start to investigate why this child is not growing appropriately. Okay, let's see the weight. Weight now is 14 kilograms and it's above the 75th centile, so not as normal as it looked here. Now I start to get worried. If What I do here usually is go back to the previous charts and check how this child was growing. If I find that he was somewhere around here and then he started to go to up here and then up here and then up here, then I know this child has a tendency to continue to gain weight. And I become very worried, and that's when we intervene to decrease or to slow down the weight gain. Is it important to prevent obesity and Down syndrome? Of course. Obesity leads to significant health issues in general, but in Down syndrome even more. And one of them is diabetes. Obese children will have less chances to, they're going to move less, and so they're going to participate less in the activities. And you know how important activities are for children with Down syndrome. Now, prevention of severe weight gain is much easier than treatment. That's why we do these plotting on charts for every visit since the first visit the child comes. And when a child is born with Down syndrome, I like to speak to the parents about the importance of the whole family eating healthy. And the reason I do that is that we see very often a child who's just 4 or 5 or 6, and they're overweight, and you want to start a dietary restriction, and it's so difficult because everybody in the, food is freely available in the house. You have all the pop drinks, the soda pops, the sugars, the sweets. And when you tell the parents that you have to stop these, they say we cannot control the whole household. We have teenagers, we have older children, and they won't accept not to bring the food into the house. And then now you have this Down syndrome child who needs to see all his siblings eating, and he has to, or she has to avoid it. So that's really, really difficult. And that's why once a child is born with Down syndrome, after the second or third visit, we get to know each other. That's the time I start speaking to them about changing the whole habits of the family, and I ask them about dietary habits at that stage. Okay, so by now I think you know what anticipatory management is. Regular follow-up of children with Down syndrome in a multidiscipline clinic. So you have with you the hearing, the ear doctor, the eye doctor, sometimes the heart doctor, the cardiologist, or the dentist, and so on. And this follow-up has shown to improve outcomes by early detection and prevention of complications and their severity. It also decreases the number of visits to the hospital because you're getting one stop but multiple visits at the same time. Okay, so and examples of what we do in the multidiscipline clinic is we check the thyroid levels, we check the hearings and the vision, the development, the constipation, the weight gain, and all these examples that I gave you. Okay, let's go to our next family. This is a couple who are happily married. They've been trying to get a child for 4 years, and they're finally pregnant. She's been following up with her doctor, taking care of her health. She does not smoke. She does not drink. She even stopped consuming coffee during pregnancy, very health conscious. She's on vitamins and folic acid, and her ultrasounds are always normal. And they showed that she's carrying a boy. And she and her husband prepared a beautiful room and bought him nice clothes, and they made a name list. This is a normal couple going through a very happy event. What happens now? She delivers at 3 a.m. on March the 3rd. The baby was blue and floppy. Floppy means the tone of the muscles is decreased, and there wasn't a lot of movement. So the pediatric resident on call, so that's a doctor in training, was called immediately, and he gave the baby some stimulation. And the baby immediately started to move, and then he cried, and so things were moving well. But then the resident or the doctor felt that the baby looked different. And at this point, I'm going to tell you that that baby had Down syndrome. But for this resident, who hasn't seen a lot of children with Down syndrome yet, wasn't quite sure what he was dealing with. And so he starts to ask the mother various questions. And I'll leave the questions here for you to see them. But my question to you is, what do you think about the doctor's questions? So from a scientific point of view, they sort of make sense, and he's asking things to help him decide whether or not this child is affected. But what is it from a psychological point of view? So the mother now becomes very worried, and she will never forget the words the doctor said after that. So what were these words? They could have been anything. There's so many different experiences to what those words were, and that's why I left it to you. But what you need to know is that any parent, most parents, will remember those words until many years afterwards. So studies show that the first encounter of parents are likely to have a very strong effect for a very long time. Whether that is positive or negative, that's another issue. Okay? And all healthcare providers who are likely to first discover a diagnosis of Down syndrome should be specifically trained to deliver the suspicion and should be skilled in carrying out the conversation to follow. So it's not enough to know how to tell them the news, but you also have to understand that there will be a reaction and a counter reaction, and there will be a discussion at that point. And this always reminds me to tell you about this very nice story written by a woman who had a child with Down syndrome. And she describes her experience as someone who was planning to go to Japan. So she bought the tickets, she prepared everything, she read about it. She was very fully prepared and got on the airplane. And when they landed, they said, "Welcome to Holland." And she was shocked and she was angry because this is not what she agreed upon. And so she was so angry that she could not appreciate anything in Holland. And it was only after she could accept that she's now in Holland and that she's no longer going to Japan for now, that she could start to see the beauty in Holland. And that's how she describes her experience to other mothers and fathers, in that Holland is more like the child with Down syndrome and Japan is a child without Down syndrome. And they're both beautiful. They're both beautiful experiences. But as long as you're thinking and concentrating on Japan, you can't see the beauty of Holland. Okay, my next family is Rami. He's 7 years old with Down syndrome. And his teacher noticed that Rami hasn't been learning well for the past month and that he's getting sleepy in class. And she told his parents, and they had also noticed that he's been less active these days. So what could be the cause? There are lots of medical causes. I'm not going to go through all of them. But just for parents, I want them to be aware that there are times when the learning slows down and then it picks up again and so on. But if it's significantly decreased, if there are other concerns, then it's worth discussing this with your doctor to just make sure there isn't one of these important treatable causes that cause this. And a very important one is sleep disturbances, which can just occur for no reason, or it can be due to not sleeping very well at night due to the obstruction in the upper airway or down or in throughout the airways. And so the child gets sleepy in the daytime. Okay, my final family is this couple, Amal and Ayman, who have a daughter with Down syndrome. Her name is Amani. These are not real names. And now they want to get pregnant again, and they want to know the chances of having another child with Down syndrome and whether they can prevent this or not. So we all know that Down syndrome results from the presence of an extra copy of chromosome 21. And these are all the chromosomes in the body, and we have two of each, but in the case of Down syndrome, there's an extra copy of this small chromosome. And in general, there's a lot to talk about, but I'll just summarize this in saying that there are 3 types of Down syndrome from a point of view of chromosomes. The first type is called non-disjunction, and that is 97 to 98%. Most cases of children with Down syndrome will have non-disjunction, and it looks like this on a chromosome analysis. There's a smaller proportion, 2% almost, that have a different picture, and it's called translocation. And then there's a very much smaller percentage where which are called a mosaic type of Down syndrome. And in that case, there's like a mosaic. So you have some normal cells and some Down syndrome cells that look like this. And to make this more visual to you, if we took Amani's, what we're going to do in this case, we're going to look at Amani, the child with Down syndrome's chromosome. If in most cases, 97%, it looks like this, then she has non-disjunction, and the chance of having a second affected child is 1% or less. So out of 100 couples who get pregnant again, 1 will have a child with Down syndrome, and 99 will not. If she has mosaicism with some affected cells only, the chance is very, very low. It's less than 1%. Now, if she has the translocation, which is only 2% of all the cases that we see, then we'll check the parent's chromosomes. In more times than not, the parent's chromosomes will be normal, and again, they'll have a very small chance of having another affected child. But if, however, one of the parents carries the translocation, and we see it on the chromosome analysis, then there might be an increased risk. And that risk depends on which parent is carrying the translocation and which chromosome it is on. In all cases, a man can have genetic testing for the fetus when she's pregnant. There is no cure or treatment during pregnancy. So either there's a big chance that you're told that the child does not have Down syndrome, and then you carry on your pregnancy with a clearer mind. But there is a smaller chance that the child is affected. And then some mothers like to know, some parents like to know because that helps them prepare. And there are some who will opt for termination of pregnancy, and that's an issue for a whole other discussion. In all cases, what you need to know is that the majority of cases are not inherited and do not recur. Nothing you as a parent did or did not do could have caused or prevented this. And it doesn't matter where it came from. Did it come from the mom's side or the dad's side? Will not make any difference, and we will not look for that during our testing. Finally, what I'm trying to say throughout this talk is that there are lots of factors that can improve the outcome, and one of them is the clinical care to prevent complications. It's not the only factor, but it's a very helpful one. I'd like to finish with this slide. These are 4 children of different ethnic origins. There's an Indian child, a child from Saudi Arabia, from the south part of Saudi Arabia, a Chinese child, and an Ethiopian child. And I think you can tell that number 1 is Ethiopian, number 2 is Saudi, number 3 is Chinese, and number 4 is Indian. And what I'm trying to tell you is, although one chromosome is the same in these, the extra 21, but all the other chromosomes come from different backgrounds. And so although the children look alike, there's a lot of differences, and they are individual. And I'd just like to thank you all for your kind attention, and thank you for the parents and the children. I'll just try to stop this.